I really love talking about and giving you guys lots of examples on the topics that we're talking about. And this is one full of examples. So this is a goodie.
Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners disrupt the norm by throwing away the rainbow art and being the best you can be when working with older adults.
If you're an occupational therapy practitioner or fieldwork student working with older adults, let me tell you a little story about how the Learning Lab membership could help you be a more confident, competent, creative, and downright more effective evidence-based practitioner. Imagine that you're sitting at your computer on a Monday morning trying to figure out what to do with your patient to be effective, client-centered, and let's be honest, we just want to have a little bit more fun. Except you did that thing again. You went down the rabbit hole and spent all your time digging around on Pinterest and Googling, and you actually never really found what you're looking for again. So you end up logging into the lab, finding the exact treatment idea you're looking for, printed off the patient handouts, and even popped over to the exclusive group just to get some more feedback. Happy you're going to get back to doing what you want to be, treating patients, and are relieved by the thought that you don't have to waste your time and energy sifting through other information that may or may not be evidence-based. What's the bottom line? The Learning Lab is full of occupational therapy treatment ideas, resources, assessments, and support like nothing you've seen before. So join the Learning Lab today at seniorsflourish.com/Learning Lab. Welcome everyone to the Seniors Flourish podcast. My name is Mandy Chamberlain. I'm an occupational therapist and I talk about everything having to do with occupational therapy, working with the older adult, professional issues, and lots of really just great topics around the profession of occupational therapy. And today I have Rafael Salazar II. He is an occupational therapist and the owner of Rehab U. And we're going to kind of dive into and talk about the biopsychosocial principles and how they apply to occupational therapy and how we can, I think in general, just kind of get better results by looking at it from a more holistic perspective. So, hey, welcome. Thanks for joining me today.
Hey, man, it's good to be here.
Well, I like to just dive right in. Let's just get rocking on this. So let's talk a little bit about your OT journey, how you got into OT, and currently, what are you doing in the OT world?
Sure. So, I did not intend to go into OT at all, really. I was actually looking at my dad's an engineer, and I had considered going to school to become an engineer and following in his footsteps and all that. But my grandfather was a vascular surgeon, and I remember being in the healthcare space, and I was kind of gliding towards doing something with people. And the idea of doing calculators and numbers didn't really sit well with me just because I need to interact a lot. So the summer before my senior year,
Yeah.
I actually was fishing out at the river and fell on a bottle and cut my FPL, my flexor pollicis longus, for all you hand nerds out there. And I landed in an OT clinic 2 or 3 times a week for the balance of the summer before my senior year in high school. And it just came, I mean, it's never a good time to end up having a tendon repair and surgery and rehab, but it came at a good time for me because I was kind of figuring out what I wanted to do with life. And, through that experience, I really fell in love with OT. I wanted to be able to help people get back from injuries the same way my therapist helped me. So that's how I kind of got into the field of OT and became interested in it. After completing school, I went to work. I did a short stint at a skilled nursing facility, and that was a little overload for a new grad. I was managing 2 facilities. I was the only OT in charge of 6 codas, 50 beds in each place. It was a lot. It was one of those like sink or swim, and I felt like I was starting to sink a little bit. So I did that for about 6 or 7 months. And really, I fell in love with the geriatric population there, but I really wanted to get into doing hands. And a position opened up at my local VA hospital in an outpatient orthopedic specialty clinic. And I did that for close to
Mm-hmm.
5 years, 4.5 years I was there, and we treated everything from shoulders, elbows, hands, fingers, the whole 9 yards, pre-surgery, post-surgery, chronic pain, um, all of that. And then about 2 years ago, I was just kind of poking around and seeing what was out there. And I ended up getting contacted and hooked up with somebody who was looking for an OT consultant. And one thing led to another with that. And I ended up leaving the VA to do some consulting work. And what that work was involved helping the state of Georgia transition folks out of state institutions and then supporting them in the community. So these are folks that have been in
Whoa, that's a cool job.
yeah, very unique. So these folks have been in the institutions basically since they were children. You know, they were either orphans or their family brought them there and couldn't support them, and they've been there for decades. And we're helping them transition out, and we do everything from actual hands-on clinical recommendations, but we also do a lot of upper level. We're setting up processes and helping develop the infrastructure for the state of Georgia to support these people once they're out of the institution. So that's kind of what I've been doing for the last couple of years, in addition to Rehab U, which was one of the reasons I was looking at maybe leaving the VA. And that really is it's a company that's designed as an advisory company, and basically what it does, I help private practice owners improve patient engagement and experience, and part of that leverages biopsychosocial principles from some of the work I had done at the VA and some of the experiences I had doing that, and then so that's basically where I'm at now. I'm on the board of directors for NBCOT as well, and then I serve on the state licensing board in Georgia, and I also teach part-time in an OT department. So I got my hands in a lot for sure.
Yeah, that's what I was just going to say. I was like, oh my gosh, you're kind of like doing a little bit of everything.
Yeah, it's fun. It keeps me busy, keeps me interested, engaged.
Yeah. That's really neat. So you were talking about using the biopsychosocial model and kind of so that's what we're going to kind of dig into today. So let's just, if that is kind of like a new concept for people, or if it's something that we need to be refreshed on because, we haven't really thought about it in many years. Do you want to kind of just like maybe go over like the background of just kind of the basics of what it is? We'll start there.
Sure. Yeah. So I like to say that the biopsychosocial model is really OT. It's fundamentally is what it is. But so it's not so much a treatment plan or an intervention as it is a philosophy of care or sort of a guide for practice. And what the biopsychosocial model does is it takes into account both the physical or biological systems or dysfunctions or pathophysiology going on, the psychological factors or components of that patient, and then social and environmental components, and it kind of integrates it all together to make one unified approach to treatment, as opposed to somebody comes in, it's from the outpatient OT world, it's very easy to somebody comes in with a hand injury and you're looking at, this is the tendon and this is the range of motion goals that your surgeon has for you, and we're going to work on that, without really taking into account the patient's subjective experience of their injury or disability and how that's affecting their engagement in treatment and all that sort of thing. So in a nutshell, that's kind of what the biopsychosocial model is. It's really, like I said, sort of just a guide to practice. Like, how do we look at a viewpoint of how do we look at our patients? And it's based on three basic principles, which I sort of touched a little bit. But the first principle is that there is a relationship between psychological and physical factors that affect health, and they're extremely complex. So that's principle number one, which basically means we can't reduce a patient's experience or a patient's disability down to one, their physiological factors, right? There's more at play. We're not just joints and tendons. So that's principle number one.
Yeah. And that's hard.
Yeah.
And that's so hard, I think, especially if you're working in like an outpatient setting, because you're seeing, you're quote, seeing a patient for an elbow or lateral epicondylitis or whatever
Exactly.
that may be. And so, so it's nice. I think it's kind of like a good reminder. So, okay, that was principle number one. All right,
yeah.
what's the next
So
one?
the second principle is that those factors, so the psychological and the physical and the environmental factors, affect each individual differently, which is sort of intuitive, but what that basically means is that we're not dealing with a string of patients that are all identical. We're dealing with individual patients that have an individual and unique subjective experience to where they're at.
Mm-hmm.
And
Okay.
so again, like if you're in an
All right.
outpatient ortho model or something like that, where you're cranking out shoulders every day, it's very easy to fall into sort of your protocol. Like this shoulder comes in, every shoulder comes in, they get this exercise, then I do some of this manual therapy, then I put some ice on them, they go on their way, they come back in a couple weeks. So this principle really is speaking to the fact that they're not all the same. And then the third,
Yeah.
yep. All right.
Okay.
And then the third principle is that a change in one of those factors, whether it be the biological, the psychological, the social or environmental factors, will create or has a potential to create real and notable changes in the other factors. So, somebody has a marital dispute, and they're under a lot of stress, and they also happen to have a diagnosis of chronic musculoskeletal pain, it is not uncommon to have a flare-up of pain and increased pain and decreased mobility out of something that's entirely non-biological, right?
And I think those are the things that are really hard, especially I think for new grads. Just from my experience working with a lot of new grads, like through the learning lab and things like that, like when you have like your clinical instructor or someone's like, they have a question and then you're like, it depends, right?
Yeah,
Everything always depends.
exactly.
It's not, especially in occupational therapy, we really, we know that people are not cookie cutter and that we are occupational beings, and we have this whole, we have to look at it from that holistic perspective, or a biopsychosocial, if you're doing it from that model standpoint. I mean, it makes complete sense, but it's hard because you're trying to, learn and figure out how all those things interact and how that impacts each of the other areas of a person's life, like mental aspect and their environment and their actually physical things that they are displaying and having troubles with. So it's I love that. I love the perspective of that, and it's such a good kind of reminder to, because I feel like a lot of times a lot of us will do that naturally, that have experience, right? We look at that from that standpoint and understand those impacts. I think some of the challenges sometimes are like, how do I document that and show that and get that covered and those kind of things? But what other kind of, is there any other kind of challenges that you see that might, around these principles that might make it
well, I think you mentioned one of them, that it gets easier as you have clinical experience. I remember the first shoulder patient I saw at the VA, and then, it was an outpatient orthopedic specialty clinic. We're serving, I had doctors, surgeons calling me, talking about this patient that was coming up to see me. And as a newer graduate, or as somebody that was fresh in the upper extremity world, it could be very intimidating. And it's like, I just need to survive. Like I'm trying to remember the four components of the shoulder complex and how they interact with each other. And I like telling the story. My mentor in that clinic was an older OT from Tennessee, and she put her arm around me and she said, honey, a shoulder is a shoulder is a shoulder. You treat them all like shoulders. And it's that's very tempting as a new grad, that you're already semi unconfident about what you're doing, to be like, oh, okay, I got this. They're all the same.
Yeah.
And that works for about 2 patients until you realize that they're not all the same, that every patient is different. So that the biggest factor probably or the challenge with that stems from either a clinician's lack of confidence in their own skill, or the fact that they really are new to the profession and they're kind of drinking from a fire hose, so to speak. It's one thing to be doing case studies in school in the classroom, and then it's another thing to have a patient sitting in front of you in a lot of pain, and you are their hope for relief. And that's a lot of pressure for somebody that's just started.
Yeah. Yeah, because it's not always so well, it's
Exactly.
not black and
Yeah.
white at all.
And then some
Like
people fall into this,
like you
feeling
said.
like uh, I've got to do a biopsychosocial treatment or something like that, and they're worried about like what intervention. And the
Right.
reality is,
Right.
like I mentioned, this isn't a treatment. It's not an intervention. It's just kind of a philosophy for how you look at patients. And once you understand that and kind of understand that
Mhm.
it's really just OT, we're looking at individuals that are in individual situations. It becomes a lot easier to say, oh, you know what? Like maybe there is something at play over here or something over here, and I don't necessarily need to. Maybe I'd need to document it, but I don't necessarily need to come up with an intervention plan for it. I'm just going to take that into account when I'm building my treatment plan for, this rotator cuff repair or whatever it is.
Mhm. Mhm. No, yeah, it's exactly right. It's just really a hard transition sometimes. But I think it kind of becomes, I say sort of like a way of life, but it's like I think the challenges is like sometimes I think there's that gap between like a true
Yeah.
medical model, right? Like where we're trying to fix what, and then comparing that or contrasting that to the biopsychosocial model is that you're still trying to address the issue that people are having. Um, but how can people kind of integrate that? I kind of use outpatient because it's very people kind of understand the whole like of like you're going in to see a shoulder, but this applies in
Oh,
like
absolutely.
so
Yeah.
all settings, right? Like working skilled nursing, you're working in home health, you're working in acute care, but when you're in those environments that where it's like so medical or biomedically based, um, how do we bridge that gap? How as an
Yeah, I
OT,
think
how do we do
the
that?
first step is just to acknowledge that. Like acknowledge that you're in a biomedical model. I mean, a lot of organizations are beginning to move more towards that holistic health. I know the VA, since I left, has started a few large initiatives to include, spirituality and mental wellness and all that sort of thing. So it is moving that way a little bit, but especially in like outpatient
Mhm,
ortho and acute care in places like that where people are coming in with acute conditions or chronic musculoskeletal
mhm,
conditions, there's still that focus on the physical, really. So the first step is really to acknowledge that there are other factors at play, and if I'm really going to make an impact on my patients, I need to address those factors. I might not need to do an intervention specifically for them, but I need to validate their subjective experience of their whatever it is, their injury or their limitation, and then help them build a treatment plan that's going to help them reach whatever goal it is. Um, so that's probably the first step. As far as starting to
mhm.
incorporate some of that into practice, a lot of that comes during the first your first appointment with the patient or your first interaction with them, because that is the key. You set
Yeah.
the tone basically for the whole treatment right there. And if you come in, I tell this to my students, I tell this to my clients, like if you come in, the patient has, let's take a patient with chronic pain, for example, and they've been to 3 or 4 clinicians, maybe they've seen a doctor, maybe they've had this MRI or that imaging study, and they've been bounced around, basically passed off. We don't know, nothing's wrong with you. I don't know why you're having pain, bounce you off
Yeah.
to another clinic, and they finally land in front of you. You have to understand at the outset, like that patient already has expectations of what, how the appointment is going to go. And you need to understand that those expectations are generally not high. Like they think you're going to run them through the mail, check a couple check boxes, and tell them there's nothing wrong
Right.
with you. So
Yeah.
first, acknowledging that, I had patients that were at the VA with chronic pain for years and years, and they'd been in and out of pain management and ortho and neuro, and they'd land in front of me. And I would always, come up, ask them what was going on, and I would just stop and say, "Listen, I know I looked in your chart and I know you've been bounced around from clinic to clinic, and I know it's frustrating, and I know it really can be stressful and cause anxiety, really, not to know what's going on. And I can't promise you that I'm going to tell you what's going on and that I'm going to be able to
Mhm.
fix it to 100%. But I can promise you that I'm going to do my best to help you with whatever limitation it is that brought you here today. And if I can't do it, I'm going to send you to the place that can. I'm going to refer you to the place that can." And just that, taking the time to say something like that, like you can't bill for that, right? But just saying it those patients, like their guards came
Right,
down. They
right,
were
right.
much more open to me during the evaluation. They showed up for therapy. They were actively engaged in treatment, and that's half the
Yeah.
battle. There's a lot of research these days coming out that links the patient's engagement in treatment, which is also intuitive. Like, if they're engaged in treatment, they're going to have better outcomes. Well, how do you get a patient engaged in treatment? You have to let them know
Yeah.
that you think that they're a real person and not just a shoulder pain or a diagnosis, fill in the blank, that you're trying to treat. I think that's the biggest step, is just acknowledging and letting the patient know that.
Mm-hmm. Yeah. No, that's such great insight there. And I mean, like, acknowledging, like, you with your example, just talking about, like, if they have the pain, right? And they're being bounced around, like, just acknowledging that you believe that their pain is real. And that, I think, is huge for a lot of people, especially with chronic pain, because you have so many people saying there's nothing, physically wrong with you, or there's all these things that go into it. And just listening to them and knowing that they are a person and that you believe them and you're going to do your best ability counts for so much.
Yeah, and
It's
that really
amazing,
is
those
pulling
things.
from the biopsychosocial model, right? Like, all the neuroscience research is coming out in
Mm-hmm.
support of this now, but like, there are no pain receptors in the body, right? There are no pain nerves. There are sensory receptors that send signals to the brain. Yeah, and the
The
brain
brain.
is,
Yeah.
creating the
Mm-hmm.
sensation of pain really as a protective mechanism, arguably from like a evolutionary standpoint, to keep your genes in the gene pool, or it's protecting the organism. And for a long time, that piece of understanding wasn't there.
Mm-hmm.
So patients really were being told, there's nothing wrong with you. Your x-ray is fine. And that can be like, think about what that does to a patient. You're
Right.
really feeling pain. You really are having trouble with XYZ. And then your healthcare professional is telling you, well, there's nothing wrong with you. Like, talk about destroying trust, talk about
Mm-hmm.
creating despair for these patients. Like, they're not, like, what's the hope of recovery if the doctors can't even tell me what's wrong with me? So really, it is
Right.
very much the
Right.
biopsychosocial model at play there, where we can come in and say, listen, we know that pain is always real. I can't feel what you're feeling, and all I can tell you is this is what the x-rays say, but I know that if you're feeling pain, it is real. It is a real sensation that you are experiencing. And then you get into things like,
Mm-hmm.
gosh, what's his name? Adrian Lowe, who's a physical therapist that runs the International Spine and Pain Institute, has a whole series of books and a whole learning platform called Therapeutic Neuroscience Education, which really leverages this, which takes the basic principle is that patients are experiencing pain. We know they're experiencing pain and it's real for them. Their brains might be, creating or
Mm-hmm.
inputting some sort of pain sensation, um, out of either being oversensitive or whatever, the hyperactive, and what they're doing is they've developed sort of an educational intervention where you basically sit down with a patient, you explain to them how pain works, like, this is what pain is, this is, your brain is making
Mm-hmm.
this pain, and I know it feels very painful when you're moving your foot, but the fact that your x-rays and your MRI are clear means that it's really a problem with your brain trying to protect your body. And what we need to do through therapy is reteach your brain that it's okay and it's safe to move your foot again, or whatever it is. And they've been seeing a lot of
Mm-hmm.
positive outcomes in those patients that have had
Mm-hmm.
chronic pain for years, going through some neuroscience education in conjunction with normal therapy, having better outcomes. I mean, that's a perfect example of leveraging that psychosocial component, right? And using it in a setting that, for the most part, you would get
Yeah.
what, like a TENS unit or some stretches and some manual therapy and a home exercise program. One little change
Right.
and you're getting a lot better outcomes.
Right. Gosh, isn't that the truth? I mean, people just want to be, I mean, part of it, honestly, is people want to be heard. And in using those, therapeutic use of self to kind of assist and guide that is so important. Kind of reflecting on what you were just talking about, like, example, a lot of times people who are working maybe in a hospital setting, or where there's more of a biomedical focus. a lot of time people will say things like, I don't feel like I can kind of intervene or, touch on more of the, the psychosocial side, not necessarily like the environment, but like more of like the emotional components, because the reimbursement, like they're saying like, okay, like we're all ADL goals and we're, working on this and this, and this is what the only things they'll pay for. How do we integrate some of those things? And you kind of touched on a little bit, but like, how do we integrate that into our daily practice, to really enhance those goals without actually, I shouldn't say without directly addressing it. Do you know what I'm trying to say? Like, how can we still make sure that we're looking at a person and treating them holistically without having to write a mental health goal?
So,
do you know what I mean?
I used to cover, part of my job at the VA was also covering acute care. So I feel that where you're trying to address, their deconditioning without addressing, without explicitly addressing something else on paper. I think part of that does come down to that therapeutic use of self, and obviously not every interaction or every minute that we treat or that we're with a patient is directly billable, right? But part of what we can do is document what may be affecting on. So if you're doing an assessment or something like that, documenting factors that may be affecting the issue that you came in to address, right? Like if it's a patient with chronic pain and that's why they're there to see you, it is entirely appropriate to dive into some of the psychosocial and emotional components of that during the assessment, and then document that in your eval. Like, this might be, exacerbated by XYZ. You don't necessarily need to write a goal about it, but document it. And just the fact, again, that you're exploring that with the patient is building trust. And then while you're doing treatment, while you're working on an ADL or while you're doing an exercise, like, you can address the fear of movement or the catastrophization or whatever it is that you're trying to address in order to make them or get them to a position where they're able to accomplish their goal. And you can document that in treatment. Like I've documented that as, patient was completing this exercise when they, experienced this sort of fear of movement or whatever. Therapist reassured them, instructed them on this XYZ, and we kept on trucking. Like, that's totally appropriate. And you're not billing a mental health goal. And you're not talking about billing or setting mental health goals even. But it is part of, that's part of our responsibility, I feel like, as OTs, is to address the whole person. And sometimes you can bill for it, and sometimes it's just part of the therapeutic use of self and building rapport with patients.
I know you can't see me, but I'm like sitting here like nodding. Yeah, that's exactly right. But because we do it all the time. But I do think people kind of feel like they need to have some sort of goal, and then they kind of like, people get worried about like, is it going to cause a denial or this? Like, that is a component, because people are like, we're addressing them holistically, and we have to address some of the we have to address those parts of our patients' lives and how they're feeling, because it is a barrier to occupational performance. And like, you can't necessarily, like you said, fear of falls or a fear of movement or, anxiety, like that. You may not be specifically addressing that, but like, because of that, you cannot achieve the goal of, I don't know, lower body dressing, right? So you have to have that addressed. And I've talked to so many experts and, talking about documentation and Medicare and things like that. Is like, people are so afraid of writing the wrong things for denial. But actually the thing is we need to just paint the picture of the patient and have them have a good understanding of what is going on, and how that is a barrier to the goals that you were working on. I mean, because it might not always be that they just can't, like, they don't have enough fine motor skills to, I don't know, lace a shoe, but it could be something bigger than that, or those external factors that really are impacting that.
Yeah,
and it's okay to write that down. I guess I'm just trying to like stress that enough, because that is honestly a question that people really have. And I totally get that, because like there's so much pressure from external, like, payment systems, and you have your bosses, and you have everybody like critiquing your documentation. But as long as you can paint the picture and explain what you're doing, why you're doing it, and is it working or is it not, or
Documentation.
reevaluating, it's okay to address
And
those
I think,
things.
Exactly, yeah. And I think as we
Documentation.
move forward in healthcare in general, like there is a pressure, and I've been there. I've been in the clinics. I've been, in multiple clinics. I've been in the situation where you're having to
Yes.
document range of motion advancements in order to justify more therapy. I do understand that, but at the same time, if you look at it from where healthcare is going,
Exactly.
which is really
Yes.
much more of a consumer driven or a value based, however you want to call it, they're trying to open up access. They're trying to let patients decide, what do we really want to be documenting? Do we want to be documenting that patient came in, did 10 reps of this exercise followed by 10 reps of this exercise, did this activity, got the ice, went home? Or do we really want to take the time to document, they did this exercise focused on, improving this functional outcome or whatever. Patient might have, whatever the factor that we addressed was, we painting that picture, but it's justifying our existence much more than the bare bones exercises, calling it a day, because what we're looking for now is value. And if you can look at 5 of your notes, 10 of your notes, and they're all basically the same thing, why are patients coming to you? Why can't they just do that at home? Why can't they do the exercises at home and come see you to get range of motion measurements? Because that's not skilled therapy. Right. Anybody can tell somebody to do, stay within the therapeutic range, 2 sets of 15 reps every other day. Boom. Like, no more therapy needed? No, like, you need the therapist there. But if all you're documenting is the exercises, you're not showing your value. Why are we paying you if all you're doing is writing down the exercises? It seems like we can get a tech to do that.
That's why the skill term. I mean, because the thing of it is I really do believe people are doing in general, like skilled services, but it's sometimes, I think it's that transition to writing it down on paper is really, really challenging for them. But you're exactly right. Like, we don't need to be writing down, progression of 10 exercises, which is great, but you have to have that subjective part. Like, how are they feeling? How, like, are they feeling like, like you have to have the whole, it needs to be bigger than that. And I think we are moving towards that. I think that's what they're trying to do with some of these payment systems, and which is, it is a transition, especially for those of us that have worked for a long time, in the field, and you really have literally had to just fill out the exercise chart.
Or treat them for this many minutes because that's their rug level, like it's a big change for sure. But hopefully at the end of the day, it shakes out better. I would like to think that it will. It's an opportunity for OT to demonstrate its value, if nothing else.
Yeah. I mean, and there's like, that's a whole nother conversation.
Yeah. I was in class the other day and my students were asking about PDPM, and I was like, oh, that's for another day.
So I know. That's the stuff that is a whole nother topic. Yeah. But I mean, like, even like the skilled, just talking, kind of getting back to like, using that skilled terminology, and kind of making sure that not only are we using skilled terminology, but that we're really painting a picture of what is happening in the session and why we need to be there, and what's working and honestly what's not. And then what are we going to do about that? Okay, if this isn't working, we can, there's no reason why we can't shift direction and just document why. Like, there could be those environmental or those other factors, more of a psychosocial factor that could be, limiting that. So I guess as an example, let's say you're working with someone with dementia, right? And you're trying a technique that you think might be valid, but then, it's just not working. It's okay to document that it's not working. And then you can even document why it's not working. And then you're like, I'm going to try this strategy next time. And I think this might be great because X, Y, and Z. That is painting a picture and being a more holistic and
absolutely,
actually just like client-centered.
I had a patient one time.
OT practitioner.
He was 86 or 87 years old.
So
and he fell and had a humerus fracture. So he was in early, mid stages of dementia, humerus fracture. He's living with his wife. And he was, we gave him his exercise. He was coming in, trying to do his exercise, was not able to follow commands and follow the directions for it. So, I took 2 or 3 sessions to really sit down with his wife, got him on the mat, showed his wife how to stretch him, how to do the range of motion, how we were going to sort of entice him to use that arm functionally after he got out of his sling. And I documented all of that. And, I was at the VA at the time, and that patient, he ended up making some really, really positive gains. But if I had just sat there and been like, the exercise didn't work, but I want to get my documentation, I want to document that I'm doing the exercises so that, XYZ can pay for it, it would have been a disservice to him, right?
Yeah, no, that's a really great example. I mean, it's just using that. So, okay, let's say, like, example, me, I have been out and, working clinically for the last 17 years now. And we learned biopsychosocial back in the day. And you're like, oh yeah, I think I kind of I know exactly what that is. I'm like, kind of wanting to brush up on it. What are some key takeaways that you think that people should kind of keep in mind if, we're like, okay, really, maybe I am just being more looking at it from a medical standpoint, like strictly medical. How could I integrate more of those biopsychosocial, the model,
I think it's
into
important
practice?
to sort of do a self-audit on yourself every now and then, and really look at, if you have templates. I know in the outpatient world that they're a big fan of templates for assessments and things like that, but pull just a blank assessment template out and look at it, and take a sheet of paper and put 3 columns in it. One is going to be physical or physiological, one will be psychological, and one will be environmental or social. And take a look and just write under each column what every aspect of your assessment is what it falls under. And obviously doing that, you will see if there's a disparity between any of them. Like, oh my gosh, we don't ask at all about their living situation or how their relationship with their family, or do they have a strong social network and strong social support, especially if you're dealing with folks like side issue that have a history of trauma in their past or something like that, like we had in the VA. Like, if you're not addressing strong social engagement, you're going to have issues. Absolutely. So really taking just a hard look at your assessment tool, or your assessment tools, plural, and see, am I adequately addressing each of these areas to an extent that I'm able to make either some sort of change or modification of my treatment plans to better affect change on behalf of my patients. So that might be step one, is just taking a look at what you're looking at. And I always was a fan of listening to the questions that therapists that I was working with or was in charge of or whatever had to ask their patients. Like, are all the questions you're asking your patients during a standard interview, during an initial assessment, or just during a treatment session? What are you asking about? Are you asking about range of motion and doing their exercises, or are you really digging a little deeper, asking the why questions, like, why aren't you able to do your exercises, or what makes it difficult to do upper body dressing, or is there anything that do you notice it's worse at this time or that time, or like something that's a little more deep than just checking the boxes. Patient completed his exercises 4 times last week, as opposed to patient reported that he could only complete his exercises 3 or 4 times because he had a PTSD flashback on Tuesday and it took him 3 days to recover, whatever it was. But making sure that during, it doesn't stop at the assessment. It's one of those things that we're always looking at. We're always reevaluating or reassessing or taking stock of what is going on in our patients' lives throughout the arc of treatment, not just day one, but really every single time they come in, all the way through to hopefully they're meeting their goals and discharging happy.
That's a really good because I think people it gets back to the it depends it depends statement, but but because people especially when you're in a new setting or you're just new as a new clinician, it's like you really want kind of you kind of want the cookie cutter, even though you kind of know that that's not the way to go, but you're just kind of grasping at trying to you're like, I just want to make sure I know I'm checking the boxes. I know what I need to do. But this is how you kind of refine it. And looking at, it doesn't have to be exactly like that, because I can even think of one example of, an assessment that I had like in acute care, right? And they had, you had to get all the boxes checked. But then you're not really you may be asking, do they have a shower bench? And you may be asking about, recent falls, but like, are you digging into those, those psychosocial components that really actually honestly impact their outcomes and
Yeah,
I don't know, just
absolutely.
thriving, right?
And I think it's when you're in practice or something like that, it's very easy to focus on whatever it is, that diagnosis, and really trying to remember, for new grads or for new clinicians, like, these are the major symptoms of this diagnosis, these are the normal presentations and what kind of limitations we'd expect, and that's fine, and you should know it all, but you have to realize that, at least if
Yeah.
you're like, have my luck, patient number one with that diagnosis is going to have like the one symptom that doesn't line up, or the one dysfunction that doesn't line up, and then you're digging trying to figure out what it is. So people are different, everybody's different.
It's so true. It's like I can think of, I can think of tons of patient examples, but we had a patient that transitioned to skilled nursing after being in the hospital, and no one realized that
wow.
actually he was homeless. And that sounds crazy that people could miss that, but no one actually really asked. He didn't. No one really asked, and because he had insurance, it was like he had just kind of moved, and he was kind of like living in his like he was like couch surfing. So like if you'd ask about a bathroom, he'd be like, "Oh yeah, the bathroom has X, Y, and Z," because
Yeah.
technically the place where he was
Oh, yeah.
had it. He didn't really want people to know. Do you know what I mean? But how that impacted, obviously, discharge planning, the extra stress that he had because he was just like going from a relative to a friend's to just like kind of bouncing around. And that is why when you just do a regular evaluation and not, ask those kind of digging in. I will even say, I'm kind of like digging in, getting nosy, and people kind of like laugh about it or whatever. But it's like really our job to really be able to kind of dig into those things and look at what's going on in their lives. And
the major reason people don't get treatment for mental health issues or seek assistance because they're homeless is because they're either ashamed, or they're embarrassed, or they don't want people to look at them that way. Part of being able to take that step and dig in or get nosy really lets the patient feel like, okay, it's not just me. I'm not the only one that they're having the deal. Like, she asks this with everybody. She's nosy with everybody, or whatever it is. Like, it's just part of what we do. It's routine. Like, you might have this and this or that going
Right.
on, and that's normal, or that it's not normal, but it's not atypical. There's nothing we haven't seen, or something like that. Anything that just lets the patient, again, trust you. At the end of the day, that's what we want, is our patients to trust us and to build rapport and to be able to use that therapeutic use of self to affect change.
Oh gosh. And when you kind of start refining those techniques and you're interviewing questions, and has to go with motivational interviewing, and there's so much that goes into that. But like when you have those patients that say like, I haven't told my doctor, or the things that you learn that that they haven't told their physician, you're like, oh my gosh, this is huge, or this has a huge impact on their care, is really it made me feel good, but it made them feel great that they could, not even necessarily that they were hiding anything from their, let's say, physician or another healthcare practitioner.
There was
but
somebody
it's just more along the lines of, no one's ever asked me that before, or no one. Yeah. Yeah. And that's a huge thing. And I really do feel like OT practitioners, like that's what we're trained for. And like I really feel like we have a special and a unique perspective. And I feel like we need to just use that and leverage that to help them achieve their goals and, have the quality of life and overall health.
Yeah, we're in a better
deserve.
position to do that, because unlike a lot of other healthcare providers, like doctors or specialists that are seeing their patients for 15 minutes every 6 months or whatever, a lot of times we're seeing them a lot. We're seeing them 2 or 3 times a week. We're seeing them over a long period of time. Like, the ability for us to develop that rapport is a really powerful thing, a powerful tool that we should always be looking to use.
Yeah. And I think that's one of the reasons why a lot of us go into occupational therapy versus some of the other healthcare professional, healthcare tracks. Cause you're like, I want to actually develop those relationships with people. And I don't want to just necessarily just see them for 15 minutes and try to, fix them. But like looking at them from a holistic perspective is such a, that's one of the reasons why I like,
me too.
And love OT. So, okay. I think that was a really good, overview and some really, I think, good concrete examples of how we can kind of integrate that theory in there into more of our evaluations and kind of our treatment sessions. So want to just share with everyone a little bit about if anybody has any questions or how they can.
Really active on LinkedIn, so you can find me there at Rafael Salazar II. I know it sounds pretentious, but there's a few Rafael Salazars floating around. So you can find me there. Fancy.
Fancy.
My website is Rehab U Practice Solutions.com. And again, you can go there and check it out. I basically just help if you own a clinic, own a practice, and you're seeing patients not showing back up to therapy and you think you have a patient retention problem, we can help with that, improving patient experience and engagement. For this podcast, if you go to rehabupracticesolutions.com/seniors, I'll go ahead and set up a page that'll have some links to some presentations I've given on the biopsychosocial model, some articles, good reads, that sort of thing, if you want to read more about the biopsychosocial model.
Perfect. I'll add in the show notes as well some of the things that we kind of touched on, like about therapeutic use of self. I even have like a skilled terminology cheat sheet kind of thing where you can kind of make sure that you're using some of that skilled terminology and make you reflect and look at them like, am I just writing down what they're doing or what am I showing what our skilled services are? So I'll add some of those things in the show notes as well. Of course. It's so important. And I'll link like you said, so it's rehabupracticesolutions.com, right? /seniors. I want to make sure I have that right. Okay, perfect. And I appreciate you having this discussion and talking about it because I do kind of love the nerd out on
it's
OT
fun
theory.
For sure. I love having these kind of conversations, making real impacts in real people's lives.
Well, thank you again so much for joining us today, and thanks everyone for listening.
Do you feel like you're navigating the OT world without a map? Not feeling confident or competent in your day-to-day treatments and struggling to apply your knowledge clinically? Then be sure to check out the Seniors Flourish Learning Lab membership. It has all the treatment ideas, patient handouts, clinical resources, community support, and mentorship you need to succeed. Join today at seniorsflourish.com/learninglab.